It's my pleasure to introduce Dr. Andrew Zelenetz to talk about treatment of follicular lymphoma.
So thank you for the invitation to speak today. I'm going to cover sort of the current state of the art. We're going to be talking a lot more about the future in the afternoon. These are my disclosures. I'm an equal opportunity consultant. So I'm going to cover a little bit of what Mitchell touched on earlier, because I think there are some important features about the natural history of this disease that are important. So I think it's pretty clear that we have the outcome is improved. Clearly, the single biggest change in the outcome of follicular lymphoma has been the introduction of immunotherapy. And with the introduction of immunotherapy, we have seen dramatic improvements in overall survival for patients diagnosed with follicular lymphoma. However, initially in the LymphoCare study, but has been validated in multiple series, we can identify about 15 to 20% of patients who are destined to have a poor outcome after they have a poor outcome. Not a particularly good time to identify those patients for a poor outcome, but this concept of people who are progressing early we've learned more about who these people are. One of the things that was seen is that patients who have POD24 have a much higher risk of histologic transformation. When we looked at this at Memorial, one of the fellows and then junior attendings started to look at the question of whether PET staging was important. She made the very bizarre and strange observation that, oh, if you got a PET scan initially, you did better. And her conclusion was that a PET scan was better. It's caused about, education. But clearly, what did this show? This showed that we could identify nasty patients early with PET scans so that the patients had de novo transformation. They were taken out of the data set. And guess what? All of a sudden, the difference, the impact of POD24 was dramatically reduced. So if we look here, this recapitulates what we found in the LymphoCare study. Exactly, this could be superimposed on the Keynote curves, no problem. But this is very different than the Keynote curves. Yes, there's still a negative impact of having progression within the first 24 months, but it is substantially reduced. So here, just simply with a test as simple as a PET scan, we could actually already pre-identify some bad actors. Now, did we do better with those bad actors? That's not what we questioned here. Those bad actors just got treated differently according to aggressive lymphoma. I do have a fellow who's actually asking that question. What happened to the patients we took out of this data set? So one of the other things, and this is work from Matt Maurer at the Mayo Clinic, we recapitulated the data, sort of, and that is looking at the outcome of patients diagnosed today, in the modern era, with follicular lymphoma and their long-term outcome. Clearly, this data says you should go to the Mayo Clinic because that's where the best result was. But the black curves or the non-dashed curves represent the survival of patients with follicular lymphoma. The red curves in the first two panels and the dashed curve in the third panel represent age and sex matched controls from the general population. And what you can see is that though in the Memorial data set, because we're not as good doctors apparently as the people at Mayo Clinic, there is a difference, but the difference, even though highly statistically significant, is actually clinically very small. Okay, there's a very small increment. And this leads to this concept, which Mitch had on one of his slides, but didn't even mention, and that's this concept of functional cure versus actual cure. And this actually represents a tremendous barrier, ironically, for us, because we're very, very close. And so we start to become victims of our own success. Okay. That has happened absolutely in large cell lymphoma, where, changing R-CHOP, you change that with great trepidation because you have a lot of success. But here with functional cure in follicular lymphoma, you need to really be able to identify bad actors accurately, because you don't want to impact long-term outcome of patients who are going to do well. So clinically, we have different means of approaching the patient. We have the FLIPI-1 and the FLIPI-2. Even though the FLIPI-2 was prospective and is actually quite accurate, most of us still use the FLIPI-1 if we use any prognostic model at all, because it does predict for overall survival using 5 simple clinical parameters. Follicular lymphoma, because of our successes, is a disease of paradoxes. Even though I'm not entirely agree with the first statement, though I still keep it on the slide, because I actually going to show you later that I actually do think that some patients with follicular lymphoma are cured. But it has a very long natural history, as already pointed out, highly responsive to treatment, but with frequent relapse. Currently, potentially curative treatments have a particular risk of morbidity, mortality associated with them. So we have to take into account patients' goals and treatment characteristics. Like, well, why would we take into account, patient goals? I had a patient come in one day, and it was March, and she looks at me and she said, and she had a ton of follicular lymphoma. She definitely needed treatment. There was no observing this patient. And she looks at me, she says, my daughter is getting married in June. I am walking down the aisle with my own hair. Deal with it. Well, that was her goal. Okay. And, so we had to create a treatment approach. And this was actually before bendamustine that achieved that. And we did. So what about limited stage follicular lymphoma? Limited stage follicular lymphoma, typically we think of involved field radiation. You can add a monoclonal antibody with chemotherapy if you want. For non-contiguous stage 2 limited stage, well, then that's really advanced stage, just by a different name. And those patients should get chemoimmunotherapy. Clearly, involved site radiation or involved field radiation therapy works. Though the more localized, the better. So if you have stage 1 disease, you're going to have a better outcome than if you have stage 2 disease. There is something that looks like a long-term survival plateau in long-term follow-up with early stage follicular lymphoma treated with radiation. However, you can see that, unfortunately, that plateau doesn't really start until about 10 years. So it takes a very long time when you have a patient with localized disease to actually have some confidence that the disease has been eradicated. So, well, if single agent radiation is not enough, you can do combined modality therapy. Combined modality therapy consistently shows improvements in progression-free survival without any improvement in overall survival. So, like many of the treatments we have in follicular lymphoma, we're going to hear it. We're going to come back to this theme where we can improve some things. The overall survival we don't necessarily impact. This has led to the concept of, well, using very low dose radiation therapy for the management of localized follicular lymphoma. This was a prospective randomized trial, the FORT trial, and compare 2x2 gray versus standard 24 gray radiation. If you look at the outcome, time to progression and time to local control were both superior with 24 gray. So that should be the standard, right? Well, the overall survival is exactly the same of these two groups. So, is it really right to always give 24 gray? So at Memorial, we've adopted a somewhat different approach to this, to very low dose radiation therapy. And this is work of Dr. Imber and Yahalom. It's basically, we use a response adapted approach. You start with, we used to start with 2x2 gray until the pandemic. Now we do 4x1 gray, and the results are exactly the same, and they only have to come in once. So that's pretty good. If you have a complete response, you just are watched. If you have a partial response after repeat imaging, then you get more radiation. And so we layer on additional radiation if you don't have adequate local control. By doing this, interestingly, you can see these are the cumulative incidence of local progression. For the patients who were treated with curative intent in the blue line, the likelihood of local control with a treatment adapted approach is very good. And I will tell you, the vast majority of these patients get 4 gray of radiation and don't need anything more. So what about low tumor bulk systemic disease? Well, the standard of care has been observation for low tumor burden patients. So if you have if you're going to observe patients, you have to have a line in the sand, or at least some suggestion as to when to treat people. And so anyone who is symptomatic obviously gets treated. These are the Gelf criteria as modified by the NCCN. And then obviously, if there's an appropriate clinical trial asking the question, if you intervene early, can you change natural history? That is a reason for treatment. So in the pre-rituximab era, we had multiple large randomized trials that used different interventions that showed no difference in overall survival between initial observation and immediate treatment. And this included incredibly aggressive treatment, such as promacetobom, which has yet to be ever published in a full manuscript. I have been told that it will not be published until it's positive. Now 37 years, it's never going to be published, is my opinion. So we have the question of, okay, and that's the pre-rituximab era. What about rituximab? So this was the UK study, originally published by Kirat Ardeshna, and it was wait and watch, or active surveillance, which is my preferred term, versus 4 weeks of rituximab versus 4 weeks of rituximab followed by maintenance. The rituximab alone arm, 4 weeks, was actually curtailed early so that we have more limited data on that particular arm for accrual reasons. But these are the updated results from ASH of this year. Well, big surprise, if you didn't get treatment, your time to next treatment is a lot shorter if you didn't get treatment. Okay, well, but that's not the endpoint. The endpoint is not time to next treatment, it's time to second treatment. And I would actually argue that the people who got the maintenance already had 2 treatments, but let's not quibble with that. We'll come back to that in a second. But time to second treatment, guess what? There really is no difference. And there are no statistical differences, even though the yellow curve is lower. If we look at the time from first systemic treatment to second systemic treatment, interestingly, if you got rituximab and maintenance, you actually progressed faster. Your time from first to second treatment was shorter. Why? Because you've used up more of your armaments early on. But transformation-free survival was similar. So early intervention with rituximab did not appear to impact risk of transformation. And if we look at cause-specific survival, that is death from lymphoma, there is no difference. And if we look at the overall survival, again, there is no difference. So The conclusion from the authors was then you should use rituximab as first-line therapy. That was, I swear, the conclusion, but that's not my conclusion. My conclusion is active surveillance remains the standard of care. What about advanced stage? So I'm going to just summarize a lot of data here. There's a lot of data here, but I'm going to summarize it. FOL5 asking, is there a best chemoimmunotherapy comparing RCVP, R-CHOP, and rituximab with fludarabine and mitoxantrone? And the answer was no. The still trial that compared BR to R-CHOP actually suggested that BR was better, though this is a profoundly compromised study. It was presented in the middle, and events change of treatment in the middle of treatment was considered an event. Since the data was presented as the trial was going on, a lot of people who were on R-CHOP demanded to be switched to BR. So this is a profoundly limited trial. The BRIGHT trial, which did the same thing, didn't show any difference. So I do not think that BR is actually superior to R-CHOP, and there's no difference in overall survival anyhow. So what about adding maintenance? Okay, so we have the PRIMA trial. This was an important trial, but it's a lot like what we just saw from the updated UK study. If you add your treatments early, then you compromise your treatments out back. So yes, adding maintenance unequivocally and absolutely improves progression-free survival, but unfortunately does not improve overall survival, and that's now with 10 years of follow-up. The BRIGHT study looked at both the induction and the maintenance. No difference in induction between BR versus R-CHOP or RCVP. Relevance was an attempt to see if a lenalidomide-based regimen was better. If they had listened to us, it would at least be a frontline option because it is equivalent. And we told them to do an equivalent study, but no, they had to do a superiority study. It's not superior, but it is equivalent, but no overall survival difference with our chemo. And then we finally have the gallium study, which showed an improvement in progression-free survival with obinutuzumab-based treatment, but no difference in overall survival. So we have lots of options for first-line therapy. Chemoimmunotherapy is clearly the standard of care, but which treatment to use is a little difficult. So how do we choose a first-line regimen? So let's look a little bit at the gallium study. So here is R chemo versus G chemo. This is now at a median follow-up of 8 years. It was just updated this summer. There is no statistical difference between these curves. No difference in overall survival. There is a persistent difference in progression, failure-free survival and time to next treatment in favor of obinutuzumab. So a couple of groups, including our own, asked, well, can we look at PET scan? So since we already show that PET scan might predict for transformation, if you have highly FDG avid follicular lymphoma, maybe that's a way to help us pick treatment. And two studies sort of suggest that that's the case. There is a small trend in favor of, R-CHOP for high SUV follicular lymphoma compared to BR in this retrospective analysis. Obviously, such a study would need to be confirmed prospectively. We have a number of molecular markers. We have the M7 FLIPI, which includes the FLIPI plus 7, the mutation of 7 genes. These were selected not for their biology, but for their impact on outcome. So these are not the most biologically relevant genes in the M7 FLIPI, but interestingly, EZH2 mutation comes out and seems to be correlated with improved outcome, particularly with a alkylator-based treatment. This might actually have some biological rationale if you think about it, since EZH2 mutations have this fundamental epigenetic dysregulation. The group in Lyon developed the PRIMA23. This was a gene signature for outcome. And like all gene signatures, predicted the outcome in the data set it was generated in. Not too much of a surprise. When applied to a variety of validation cohorts, it also was proved to be valid, both in PRIMA from the Iowa Mayo Clinic molecular epidemiology resource, as well as from Barcelona. If you take the PRIMA23 and the a variety of different ways of sort of torturing the data, and you ask what is the most predictive outcome, the basically if you have a T effector signature and the PRIMA23 gene high risk signature, low risk signature, you're going to have a good outcome. And if you have a poor risk T effector signature and a poor PRIMA23 gene, you have. And is this the mechanism we're going to predict ultimate outcome? Well, I'm not sure. I don't think we yet have a reliable way of identifying the poor actors, though this is, I think, a first step. This is actually combining what we're seeing in the tumor with what we're seeing in the tumor microenvironment. And I think ultimately that's where we have to be. We need an integrated analysis of tumor and tumor microenvironment. So what's the practical approaches? You know, for limited low risk patients, I think I still use actually a lot of obinutuzumab and CVP or rituximab and lenalidomide. It's very hard to get obinutuzumab and lenalidomide approved in the US. I'm not sure why. I am not a fan at all of bendamustine in first-line therapy. Most people who know me know that my pet peeve about this, because in the gallium study, there was clearly a survival disadvantage of getting bendamustine initially. It catches up over time, but why take the risk? And it was worse during the pandemic. So I actually don't think bendamustine should be used as first-line therapy in follicular lymphoma. In high-risk patients, particularly if there's high SUVs on PET, I will use a CHOP-based treatment, though lenalidomide is actually with obinutuzumab or rituximab is an appropriate alternative. If you are looking to maximize progression-free survival, which is important for certain patients of certain ages, then maintenance makes sense. Though I will say in the US, we have largely dropped maintenance since the beginning of the pandemic. What about relapse? In relapse, we have lots of options. We have the established ones, and you may see there's a couple of established ones in red. Well, they're established, they're proven, they were approved, they're either withdrawn or not available. And so radioimmunotherapy is functionally not available in the United States or actually anywhere now. And we'll talk a little bit more about the PI3 kinase inhibitors as we go through this. This is really where biology has met the treatment landscape. Really understanding more about the tumor and how it behaves has allowed us to identify new targets for therapy. So this has allowed us to introduce new modified and unmodified antibodies, bispecific antibodies, targeted pathway inhibitors. There was a mention that why the BTK inhibitors don't work so well here. There's some controversy as to whether they actually don't work so well, particularly if you look at some of the data from Nathan Fowler and from the Rosewood trial. There may be suggestion that if you do the timing right, BTK inhibitors actually do work, and that's from a big skeptic for BTK inhibitors. We clearly know that PI3 kinase is a absolutely essential pathway in the biology of follicular lymphoma. IMiDs and cell mods and PROTACs allow us to manipulate the tumor microenvironment. PROTACs allow us to target drug proteins that we could know, but previously we couldn't target. And then we have epigenetic modifiers, which have had relatively limited impact. So high-dose therapy with stem cell rescue or allogeneic stem cell transplant remains a treatment option in follicular lymphoma. Based on the CUP trial, which was dramatically under-accrued, but still demonstrated that progression-free and overall survival was improved with consolidation with high-dose therapy and autologous stem cell rescue for relapsed and refractory follicular lymphoma compared to conventional chemotherapy. If we look at the experience from the University of Nebraska, they have created a risk model and can identify a risk model that predicts for very long-term outcome. And they actually use that four-letter C word associated with their outcomes. They feel that they're curing a significant proportion of these patients. Now, a lot of this data was generated in the pre-rituximab era. Well, that's ancient history. But even in the rituximab era, the GILA was able to demonstrate that high-dose therapy and autologous stem cell rescue had a important improvement in outcome. Allogeneic transplant still is one of the few unequivocally curative therapies in follicular lymphoma. This is not without its risk. But there are multiple trials. This is just one of them demonstrating that long-term failure-free survival is achievable. So in the relapse setting, that's where we first saw the introduction of obinutuzumab. Obinutuzumab was combined with bendamustine. This is where I actually use bendamustine in the relapse setting. I don't use it up front. This was a study of obinutuzumab and bendamustine with obinutuzumab maintenance versus bendamustine. You might say, huh? What happened? Where's all the rituximab? Well, this was only for rituximab refractory patients, so it made no sense to give more rituximab to patients who are already rituximab refractory. And this resulted in a not only progression-free survival advantage, but an overall survival advantage. Similarly, lenalidomide has been used for treatment. Unlike the upfront setting, the studies in the relapse setting were done appropriately. So rituximab lenalidomide was compared to rituximab plus placebo. And I actually don't like calling it R squared. I actually call it RL, but that's okay. I don't use trade names. So this was the time to event outcomes in the AUGMENT trial, showing a clear improvement in progression-free survival and a trend for the entire population for overall survival. But in a planned subset analysis in follicular lymphoma, there was an overall survival advantage of rituximab and lenalidomide in the relapse refractory setting. Now, one thing I do want to point out is the overall survival curves. This is relapse refractory disease. Those curves, look at them. They look really pretty good. Okay, yes, it's only 4 years of follow-up, but those curves are very high, and those are not 1995 curves. They wouldn't look like that, and that's because our treatment and subsequent treatments have simply gotten better. So overall survival has become a much more fraught endpoint in trials. That's just one of the things you learn by looking at the curves. What about taseminostat? Taseminostat, as we've heard elegantly, is one of the recurrent mutations. It's actually often a stem mutation that we see in follicular lymphoma. What happens is this is an activating mutation. So, oftentimes we think of, oh, mutation that kills a gene. No. Some of the mutations that we have are activating mutations. EZH2 is most commonly an activating mutation. And what it does is you now have oncogenic mutations in EZH2, which result in failure of maturation through the germinal center. Taseminostat is a first-in-class inhibitor of EZH2. It actually is not dependent on the mutation. So there is a basal activity of EZH2. It's just activated when it's mutated. So it will inhibit both wild type and mutant EZH2. That's just to get you ready for the next slide. So if we look at outcome of taseminostat in the treatment of follicular lymphoma, this is in the EZH2 mutant cohort. Well, virtually everyone has some clinical benefit. The response rates are high. And this is the closest thing to not giving treatment to someone that you can give. I have been accused by patients of prescribing sugar because there's almost no side effects. It's really quite bizarre. It's really great. This is what happens if you give the same drug to people who have wild type EZH2. And guess what? There still is a reasonable response rate that you see. You don't have that same dramatic, almost everyone benefits, but there is a reasonable response rate. So when you're looking for treatments and you don't have very many other options, taseminostat, because it's so well tolerated, is certainly worth trying. These are the time to event curves. Obviously, we would like to see them look better than they do, but with a median progression-free survival in the order of about a year, which ironically is about what we see in almost every single trial of relapsed refractory lymphoma, no matter what treatment we use, except for CAR T cells, transplant, and bispecific antibodies. So I'd like to talk a little bit about what I think is a tremendously important class of drugs in follicular lymphoma, and that is PI3 kinase inhibitors. Why are PI3 kinase inhibitors? Well, we already saw some of this. PI3 kinase signaling is critically important in the biology of B cells, and it's quite important in the biology of a follicular lymphoma cell. And we see PI3 kinase downstream of multiple signaling pathways in the B cell. So it's not just through the activated constitutively signaling B cell receptor, but it's also downstream of other important pathways that are causing static growth signals to lymphoma cells, and particularly follicular lymphoma. There are a wide variety of PI3 kinase inhibitors. We really want to inhibit the delta isoform if we want to hit a B cell lymphoma. And you can see that these all hit the B cell, the delta isoform, and have different selectivity for the other isoforms. Copanlisib is the closest to a pan PI3 kinase inhibitor that we use. Parsaclisib, you can see, is probably the most selective of them, with the exception of zandelisib, which I'll talk about in a second. So what's happened? Idelalisib was approved for CLL, then it got approved for follicular lymphoma. Then in the midst of ongoing randomized trials, there was some concern about increased risk of death and increased toxicity. And the trials in follicular lymphoma were held and never restarted and never completed. And the FDA, with some arm twisting, the drug was voluntarily withdrawn for follicular lymphoma and small lymphocytic lymphoma. There is full approval for CLL, and it's still available for CLL. Copanlisib likewise received accelerated approval based on good activity, overall response rate of nearly 60%, duration of response of 12 months. But there was some suggestion of a risk of death, and it has been voluntarily withdrawn based on the Chronos 3 data. Duvelisib, very similar story. Excess of toxicity, never could complete the confirmatory trials, and the follicular lymphoma indication was withdrawn. And umbrellasib, which is a PI3 kinase and a CK1 epsilon inhibitor, also had a death signal, but it was probably related to the ublituximab that was added to the treatment, but they didn't want to redo the studies, so they withdrew there. So, so these drugs that all have, high response rates and durable responses have been withdrawn because of a potential toxicity signal. So I don't disagree with the FDA that, these are potentially toxic drugs. What I do disagree with is that it's not impossible to find the way to give them. I think one of the questions is, do we really need to give them the way that we've been giving them? Do you have to give a PI3 kinase inhibitor all the time? Because it's going to inhibit the targets that are causing toxicity just as much as it's going to hit the lymphoma target. So zandelisib was, and I now unfortunately now use the term was, a novel PI3 kinase delta inhibitor. It had one of the things, it had a very long half-life, and it had very good selectivity for the delta isoform. Because it had this long half-life, you could actually model what would happen if you gave intermittent dosing. And what we figured out is that if we gave 7 days of dosing, actually there would be therapeutic drug in the system for about 10 days. But because of the tight binding to the target in tumor, there would actually be about 2 weeks of on-target inhibition of the tumor. But it would allow for T regulatory cells, which are the source of much of the toxicity, to recover. And so we actually were able to prove that. If we gave it continuously, it looked just like every other PI3 kinase inhibitor, lots of toxicity, colitis, pneumonitis, transaminitis, a higher risk of infection. But if we gave an intermittent schedule, all of a sudden we actually, in fact, if you look at the way the toxicity developed, it developed all in the early part of the intermittent schedule. And the early part of the intermittent schedule wasn't intermittent. That was my fault. So we gave 56 days of continuous dosing and then switched to intermittent dosing at the beginning of cycle 3. So we have recently presented, and we will be publishing soon, the results of the phase 2 trial of zandelisib in relapsed refractory follicular lymphoma. These are patients in 3rd line or beyond. They receive continuous dosing for 2 months and then intermittent dosing thereafter. You can see virtually all patients have a clinical benefit. The response rate is over 70%. And you can see the duration of response and progression-free survival are actually pretty favorable for a 3rd line and beyond population of patients. So this is a validated target. It's actually validated not just in follicular lymphoma, but also in marginal zone lymphoma, Waldenstrom's, and CLL, SLL. But clinical utility of the class is limited by toxicity, and that toxicity is immune mediated. And it's almost certainly via the impact on T regulatory cells. But by intermittent dosing, we were able to show we could mitigate it. But the FDA, in their great wisdom, has set the bar so high that the initial randomized study has to show no difference, an improvement or no difference in overall survival. And for any company, as their first trial in follicular lymphoma to have to wait for a overall survival endpoint is impossible. And so the company has abandoned the development of this drug outside of Japan, because in Japan they're allowing for a progression-free, sequential progression-free, and then overall survival analysis. So in the last couple of seconds, I just want to talk about a little bit about the challenges. So this, and I could show any long-term curve of follicular lymphoma. I'm just picking on Prima here, but they all look the same, okay? And why do they look the same? They all have an early phase. The early phase shows a more rapid recurrence. Then there's a middle phase that is associated with actually pretty durable, very long responses, but inevitable relapse. And then there's a terminal phase on all of these studies, which is very long. The event rate is extremely low, and the cause-specific survival is actually outstanding in this. And so that's why I come back to, I actually think we are curing patients, because we can show this in every single large-scale randomized trial, that there's this late phase. Early studies, it's 5 to 10% of patients. In the more recent studies, it's a population that is probably in the range of 20, maybe 25% of patients. These represent fundamentally different biology, okay? This, coming back to Mitch's point, this is a heterogeneous disease. And the patients, we have to understand what makes you to be in that early phase rapid droppers, what puts you in that typical follicular lymphoma forever type of mode, and who are those few patients who are actually cured and what's different about them. Now, interestingly, we have largely failed to show that even though there are these differences, that we impact overall survival. And that's, again, to this challenge that I set out at the beginning, where we have a functional cure. There is a catch-up. If you give Prima and you have this initial improvement in progression-free survival, the overall survival is decremented a little bit because you've already given a lot of rituximab, so the subsequent treatments aren't quite as good. If you've given less treatment, the subsequent treatments are better, and so you can catch up. And that's why overall survival doesn't change, but progression-free survival is different. So these are, I think, the fundamental questions that we need to be able to answer if we're going to move the field forward. Who are the patients on the early part of the curve? We know that simple mutation analysis hasn't worked. We need to do multi-omics analysis where we're looking at the tumor microenvironment and the tumor, and probably at the patient as well. And so we need large numbers of patients with adequate follow-up, and ideally a significant subgroup of patients who have multiple biopsies so we can look over time. Who are the patients on the late part of the curve? Well, yeah, we want to know who they are, because what is unique about them, and can we identify them early? Coming back to Mitch's point, no one wants to have to wait 25 years to know if they're cured. They want to know if they're cured early. So can we identify them? I don't know we can. I'm just saying that's the challenge. And then, of course, what's the role of the tumor microenvironment? We have that early data from Sandeep Dave that showed that the tumor microenvironment was critically important. We know that it is, and that all tumor microenvironments in follicular lymphoma are not the same. Now, interestingly, there's a very similar thing in early stage low tumor bulk disease. And these are data that we generated looking at time to first and time to second treatment as a surrogate for overall survival. But again, it's a biphasic curve. There's a group of patients who progress more rapidly, even though they started with active surveillance initially. Those patients are the patients who I would be happy to put on a clinical trial for active surveillance. I'm not sure I really want these patients on an active surveillance clinical trial. Why? Because they're going to dilute the effect of the treatment. They're going to do well no matter what you do. And we all have patients who we've observed for a decade, sometimes 2 decades. Some of us are old enough in the room to have people who are getting close to 3 decades of observation. You know, they have never progressed. They may have progressed, but they've never needed systemic treatment. So clearly, if you include a lot of those patients on an upfront study in low tumor burden disease, you're just going to dilute out the signal. So these are some of the major challenges that we have. So I actually did mention COP, but I call it CVP. So in my practice, the difference between COP and CVP is when we give cyclophosphamide the way it was originally described, orally 2 grams over 5 days. And if I'm giving IV cyclophosphamide, I call it COP. That's only from my own shorthand. So I can open a chart and, you know, I have some patients who I know will never take a pill of the cyclophosphamide I give them. They all get COP. They all get a gram of IV. But the patients who I think are more reliable, I'm just a traditionalist and I still give 2 grams orally. Remember that all of the randomized trials based in Europe, no offense, is not CVP or COP. It's CHOP without doxorubicin. And the difference is the dose of cyclophosphamide in all of the randomized studies from Europe are 750 per meter squared, not 1,000. And no one used 2,000. No one used the oral, the traditional 2,000. I think there was actually a difference, to be perfectly honest. But if we look, even if we look at gallium, the one chemo regimen that was most influenced by the addition of obinutuzumab was CVP. So, and I actually use a whole lot of CVP in my practice. I'm one of the last people who use it, but I use it a lot and I have very good long-term outcomes with CVP, but I will admit I use it highly selectively. So I wouldn't in a million years publish an outcome of CVP COP patients because I know I have pre-selected them. Anyone who had high SUVs, they were taken out. You know, anyone who, you know, was observed for a long period of time and had a little bit of progression and, you know, I could treat with single agent rituximab, I took those out. I use CVP a lot, almost exclusively with obinutuzumab, to be honest, since the gallium result. But I actually do like it. It's actually one of my preferred regimens if I'm not worried about de novo transformation. If I'm worried about de novo transformation, I use R-CHOP, and I don't use BR. In fact, someone insisted they get BR, and I actually required them to sign a release saying that I understand that this is not the recommendation and that there is a higher risk of early death from this because that's how much I really don't use it. So I only use CVP or CHOP, or I do use, I would say, 10 or 15% of the first line patients get RL, and usually people who say, you're going to give me chemotherapy over my dead body, right? It's in the US, it's much harder to get. It's not so trivial to get it as first line. You have to drop down on your knees and beg the insurance company. And I just don't like doing that. Now, in terms of second primary malignancies, CHOP and CVP actually have relatively very good profiles when you look even very long after treatment for second primary malignancies. Not so with bendamustine, but certainly with, and actually not so with CAR T cells. interestingly, we're starting to see more secondary malignancies with CAR T cells, but that's largely because we gave them a lot of treatment before, but that's okay. It didn't help that we give them all fludarabine just before we give CAR T cells. I don't think that helps either, but I agree with you. I think that giving a cyclophosphamide-based induction regimen does reduce the risk of second primary malignancy. One of the reasons I do it. So I don't have very many bilateral inguinal disease. Well, no, because it is an entity. Okay, so inguinal presentations are a distinct entity. They tend to be not have a 14-18 chromosomal translocation. They tend to be CD23 positive. There's almost always STAT6 mutations. There are TNF-RSF14 mutations or deletions. So these are unique tumors, and if they do end up bilateral, they usually start in one side, and then a few years later are on the other side. So I actually have very few. I mean, I'm trying to think if I have had any that have actually presented with bilateral inguinal disease. I've had them where I've resected one side. This just literally just happened the other day. We resected one side. Now, 4 years later, he had the same exact disease on the other side. And now we're radiating them on the other side. I think I would probably give that person 4 gray and see what happens. If they have the features of this favorable inguinal presentation, that means that I would check to see if a 14-18 translocation. I would do a sequencing panel to see if there were, I would see if there's a deletion 1p36 or a TNF-RSF14 mutation or a STAT6 mutation. If there were, yeah, then I would probably treat that patient with bilateral 4 gray. So I did. So a few months ago, it's like, oh, things are calming down. Things are pretty good. And I started some patients on maintenance. One of them died of COVID. And we're now experiencing a surgelet, and we've had a number of deaths of patients in remission following CAR T cells and other things. So we're very nervous about the ongoing immunosuppression.